Hello, everyone, and welcome. I'm Keith Wailoo. I'm the Vice Dean at the Woodrow Wilson School and Professor of History and Public Affairs here at Princeton. I'd like to welcome you to this obviously very timely panel discussion. For about a half decade, it's been 5 years so far, that the term Obamacare has been in the political and healthcare air. I looked it up. It was August, I think, 2009 that you begin to see the first appearance of that term. And in 2009, 2010, the question was Obamacare's creation, whether a law would ever come to be, and if it did, what it would look like and what its components would be. In 2011 and 2012, the question was its constitutionality, and the question of how different federal courts and ultimately the Supreme Court would rule on this new legislation. And in 2013 and 2014, the political battle has shifted to this question of implementation. October saw the disastrous website rollout, and since then we've seen uneven state and state-by-state Medicaid expansion and new enrollment activity that would seem to change from week to week and month to month. And amidst all of this, charges continue to fly. This is a monstrosity. This is a savior. This is a horrible thing. This is what we've been wanting all along. Will Obamacare cost jobs? Are too few young people signing up? Well, the numbers, yesterday I think it was 4 million, as early this week. Will they fall short of the target? Surely they will, but enough to declare it a failure? Or will it rise enough to declare it a success? Why have some states like Kentucky succeeded while others have struggled? And of course, every week, as I said, the story changes. No doubt, the end of next month, at the end of the enrollment period, we'll see the discussion shift yet again. So for today, I guess you could have a provisional panel discussion of where we stand and what's likely to unfold in the months, and perhaps even year ahead. For today, we've assembled a distinguished group of Obamacare observers, scholars and writers who have been following healthcare and healthcare politics for many, many years, to reflect on the implementation stage, to look back over the last few months, and to look ahead, and to draw some general lessons about what we've seen. In order of presentation, they are Heather Howard, and I'm going to be really brief. I'm asking them to be brief, so I'll be brief as well. Heather Howard is the director of the State Health Reform Assistance Network and a lecturer in public affairs at the Woodrow Wilson School, and she's undertaken some of the closest analyses I know of state efforts to promote continuity of coverage and care under the Affordable Care Act. James Morone, professor of political science and urban studies at Brown University. He's the author of Hellfire Nation, The Politics of Sin in American History, and co-author of The Heart of Power, a study of health politics and presidential leadership, as well as Democratic Wish, Popular Participation, and the Limits of American Government. Sara Rosenbaum, I didn't realize we'd arranged you guys so neatly in order. Sara Rosenbaum is a lawyer and Harold and Jane Hirsh Professor in the Department of Health Policy at George Washington University School of Public Health and Health Services. She's the author of 250 plus articles and studies focusing on all phases of health law and health care for the medically underserved populations. She's co-author, for instance, of the book Law and the American Healthcare System. And I could go on and list her credentials, but I'll stop there. Uwe Reinhardt, the James Madison Professor of Political Economy and Professor of Economics and Public Affairs here at the Woodrow Wilson School and at Princeton. He's widely recognized as one of the leading authorities on healthcare economics. He's a member of the Institute of Medicine, of the National Academies of Sciences, and as I said, I could go on, but I'll have to stop there. Let me describe the rules of the road, which is that I'm asking each of the panelists to spend maybe about 10 minutes to say some words to shape a conversation and a discussion, and hopefully from there we'll be able to, after about 40 minutes or so, entertain questions and build it out into a broad conversation that gives us some traction, some insight on what this thing called Obamacare is in its implementation stage. Heather.
Thank you, Keith. It's great to be here, and I think this is working. Yes, I'm going to use my time, but let me first ask, how do I advance the slides? Yep, there we go. I'm going to use my time to show a few slides that basically set the stage on what's the status of implementation of Obamacare, and hopefully that will set the context for our discussion. So let me jump in. I want to talk briefly about federal implementation and then jump into state progress on implementation, and then pull back on what we know about enrollment thus far and talk about some key issues to watch. So let me jump in. This is my slide on federal implementation. It hasn't gone well. This perhaps is the best picture of it, this slide, but clearly federal implementation has not gone well. And the word, did you use the word dismal? You know, there's different negative words for it's not gone as well as any of us would have hoped. But let me jump ahead because to talking about where we are on implementation of exchanges. This map gives you a sense of which states are opening their own health insurance exchanges and which have deferred to the federal government. So Jim may be able to comment later on how closely this map tracks an electoral map, but what's interesting about this map is how many states have opted not to run their own health insurance exchange, which was an option under the Affordable Care Act, but have instead deferred to the federal government. And just today, the head of CMS, you may have seen this, commented that when the law was passed, federal officials assumed that only 10 to 12 states would buck and say, we're not going to offer our own exchange and we're going to let the federal government do it. But as you can see by this map, 35 states have said, we're not going to run our own exchange, we're going to let the federal government do it. So what has that meant? To go back to the problems with federal implementation, it's meant a lot more work for the federal government because they're running an exchange in far more states. Also of interest are the green states, which stand out. They're the states offering a hybrid model. They sort of, a little bit pregnant, wanted to do some implementation, but couldn't fully do it. So this map is just an interesting test of how many states have embraced the ACA. Here's a different map, though, of a different measure of how many states have embraced the ACA. This is a map of how many states will be expanding their Medicaid program. Now, most of you know that the Supreme Court threw a real wrench in the Medicaid expansion and said that the Medicaid expansion was optional. States didn't have to do it. You would never design a federal law that way where you didn't have a federal floor, but they gave states the option of whether to expand. And so at this point, 25 states are expanding. Those are the purple states. Then you've got the hell no, we won't do it in the blue. And then you've got what are really interesting are the yellow states, the states that are considering expanding. And I'm sure Sarah will touch on this. But when the Supreme Court gave states the option of expanding, they gave the states a lot of leverage over the federal government. And those states are feeling their oats. And especially we want to watch these orange states because they're thinking, boy, we've got some flexibility. We can really push the feds. And let's see how we can do Medicaid differently. And Sarah's is probably the leading person following this state flexibility. And so I'm sure we'll get into that in the Q&A. But what are these states doing differently? And for those of us here in New Jersey, we watch Pennsylvania as one of the states that's really pushing the envelope. So hopefully we can get into talking about that. Now, one question we may want to talk about is why are there more states doing the Medicaid expansion than are doing the exchange? I think it's two things. One, I think it's more money is at stake for those states. And two, more stakeholders have more interest, like hospitals. But that's something we may want to talk about when we get into more discussions. So finally, we have some metrics. We finally know, at least have a snapshot of how things are going. And this is based on January enrollment data from the ASPE reports. So we're late in February, but we only have January data now to look at. And the good news is that 3.3 million individuals have selected a plan. I'll talk about that in a second. And 3.2 million are eligible for Medicaid. So this tells us what we know. But there's actually a lot that the numbers don't tell us that I want to make sure I highlight. First of all, we don't know how many of the people who have selected an insurance plan, how many of them actually have paid a premium. It's not an easy process to go through, and you don't actually effectuate your coverage until you pay the premium. So 3.3 is a good number. It's not exactly where we want it to be now. It's a good number, but we don't know that they've all paid a premium. We also don't know if that Medicaid number is the full number because not everyone has come to Medicaid through the main website, healthcare.gov, and through state exchanges. So we don't know that that fully represents. And the final thing we don't know is, of these folks who are getting coverage, did they have coverage before? Were they uninsured previously? Or are they just shifting from one coverage to another? And that's an important question. Are we getting new coverage to people who are uninsured? So we don't know that, and that we will know more over time. Also interesting to see what percentage of the people buying health insurance are young, and that key group everyone talks about trying to get young people to buy. We'd like to see that number higher, more young people buying. But we actually, and I think Uwe will have some interesting comments on that, it's actually more important that we see that we have the health status of the people who sign up, that we have healthy people signing. That may be more important than the age of the people signing. And the final bit of good news, I think, is this point at the bottom about the metal tiers. The metal tiers, it's complicated, it relates to actuarial value, but the higher the actuarial value, the gold and platinum is better than bronze, means you'll have a higher premium, but you'll have lower out-of-pocket costs. And there was a fear people would flock to the bronze plans. They would say, lower premium, that's for me. But they'd be getting themselves into trouble, actually, because they'd have significant out-of-pocket costs. So the fact that the bronze enrollment is where it is, we think is a good sign. It means people aren't just choosing based on premium, and hopefully they're understanding that health insurance isn't just about your premium, it may be about your total costs. So we think there are some early victories, but there are also some challenges here. After that dismal start, enrollment is steadily growing. Enrollment is growing faster in state-based marketplaces. I think that's because those states have embraced the ACA and they're doing more aggressive marketing and consumer assistance. We're still seeing in some of the states that have deferred to the federal government that they're finding ways to throw sand in the gears and to complicate implementation. So that's something to be watching. But even in the state-based exchanges, there are some that have had serious problems. Their vendors haven't delivered, they're having IT problems, and they're not coordinating among their different systems. So still problems in some states, most notably Oregon and Maryland. This is just a different way of looking at the enrollment numbers. What you see here is enrollment is growing steadily, and once a lot of the IT problems have gotten fixed, enrollment has surged. And also it demonstrates the orange bar is how many people are signing up through state-based marketplaces, and the above bar, the blue, is how many are signing up through the federal exchange. And when you consider that only 15 states are running their own exchange, that orange number is very good. Also, you'll note 82% of the people who've signed up are getting tax credits. That means their income is below 400% of poverty. That means they're considered under the federal law to be eligible for help buying their insurance. And that's a good sign. We want people who are coming in and getting assistance to make their insurance affordable. So quickly, just issues to watch going forward. We care about the overall enrollment numbers, but as I said, we want to make sure we're getting a healthy mix of young and old, healthy people, people not as healthy. We want to get that broad mix of people so that this system is sustainable. We also want to watch and see if there's any softening at the state level, if there's any trend of states saying, maybe we'll try that Medicaid expansion. Some of those states that are on the edge, those yellow states, are they going to move over? One issue to watch is churn, which is another issue in which Sarah's really been the lead in thinking about, is when people's income change and they have to shift between health insurance plans, are they going to fall through the cracks, or are they going to have continuous coverage? That's really important to think about. And finally, what does this mean for the broader insurance market? And Uwe's written a lot about this. We're seeing what people call doc shock. Is my doctor in the network? Or we're seeing this move towards narrow networks, which I think was the underlying trend anyway. But it's easy to blame the ACA for anything you don't like in the healthcare system. We're seeing an increase in the number of private exchanges. And of course, the issue of affordability. Health insurance is expensive. The number one barrier to health insurance is affordability. So we can expand access, but can we make it affordable so that people buy it? And finally, the federal government is famous for delaying many, many provisions of the ACA. So how much of the remaining provisions are going to stick, or are we going to see more delays? Just a few thoughts. Oh, and then just a final thought. That's maybe a good segue for you, Jim, which is, what does this mean for President Obama's second term, and getting anything else done on the domestic or the international front? Is this put him on the disabled list for the rest of the term? So, thank you.
Well, we can just leave that up there for my presentation. I think it summarizes pretty much everything I have to say. We're in very strange territory for anybody who studies American history. Traditionally, when Congress finally acts, the debate is over. If you look at the Civil Rights Bill, we're also at the anniversary of the massive Civil Rights Act. The Supreme Court might decide Brown versus Board of Ed, and the battle goes on. But the 1964 Civil Rights Act is it. A 57-day filibuster. Imagine, 57 days, day in, day out. There's Congress arguing about civil rights, but the day it passes, it's done, and the argument ends. What a difference, huh? One of the great questions you have to ask about this debate that goes on and on, Congress to the President, to the Supreme Court, to the 2012 election, and now to 50 state legislature governors and courts. One of the questions we have to ask is this the new normal for all social policy legislation, all big acts of Congress, or is Obamacare somehow special? So for things to keep an eye on in the future, that's a big one. Now I want to start with the enormous irony. If you're a healthcare liberal, you have spent your life writing about how markets aren't a very good way to organize medicine. They're unfair, they're too complicated, you can't trust the damn insurance companies, they won't work in rural areas, and they're complicated. If you're a healthcare liberal, you've written 10 articles, something along the lines of why markets won't work in healthcare. And I was looking at Sarah when I said 10, but I can look around this audience and see a lot of people who've written a lot of articles. And here liberals, particularly in the political system, are lashed to markets. And when they finally lash themselves to markets, what do they get? Cries of socialism from the Republicans, who've been arguing markets are the way to go. I want to focus particularly on the expansion of Medicaid in this story. And to do that, I think I have to back up just a little bit and talk about Medicaid as it was before the ACA. If you know healthcare, go to sleep for a second, because you already know what I'm going to cover. But if you're kind of new to the area, Medicaid, of course, covers some low-income people, but the variation in state programs is really quite extraordinary. Take one category, there's lots of categories, parents of dependent children. If you don't have kids, only 9 states will cover you, and it varies a little bit by too complicated things to get into in 10 minutes, but if you have kids and you work, in Arkansas, that's the lowest, you're covered up to 16% of the federal poverty line. That is, for a family of 4, if you make more than $3,768 a year, no good in Arkansas. Alabama, it's 23%. And you qualify for Medicaid, 24%, and you're gone. Texas, 25% of the federal poverty line, $5,887 a year for a family of 4, no Medicaid. That is $1 more than that. And so it goes state by state. If I had the chart, you could just see it up here. 31% for Kansas, 47% for New Hampshire, 89% for South Carolina, etc. Texas maybe bears special note, as it's got 1 in 5 people uninsured, but again, $5,887, family of 4, and you're out in Texas. So what the ACA comes along and says, no more. 138% of poverty, and you're in Medicaid. $32,500 roughly for a family of 4. Feds will pay 100% for the first 3 years, and then 90% after that. If you're a liberal, I've got a little heart in my notes. If you're a liberal, this is the heart of the ACA for you. For the first time, all people who are low income get health insurance coverage. Now, so this is very exciting. If you sort of are a liberal and you didn't like this other stuff about insurance exchanges, fear not. This Medicaid is good stuff. There were intimations of trouble even as it was going through Congress. If you were at all alive to what was going on, you knew about Ben Nelson and the whole debate in Congress, right? Ben Nelson is number 60. You got to get his vote. Joe Lieberman is 59, Ben Nelson 60. You need him for the filibuster. And I knew a Senate staffer, and every time I talked to him about the ACA, I'd say, what's going on? And he'd say, excuse me, fucking Ben Nelson. Ben Nelson was a pain in the ass. This is being watched. I've signed that form. Now, everybody knows Ben Nelson got bought off, but the Democrats might have paid a little more attention to exactly why they needed to buy him off. What Ben Nelson said was a dime for the dollar, that is, making Nebraska put in 10 cents on the dollar, it's not enough. We're not going to do it anyway. We're too red for that. We've got a very low Medicaid threshold, and it's not going to work. So how the Democrats saw this was, tough luck, everybody's going to go in, we're going to pass this thing, but we'll buy you off. So that Cornhusker kickback, famous, if you followed this, was actually, we'll pay 100% of Medicaid costs in Nebraska going forward, forever, not just for the first 3 years. And everybody that finally dropped out, it was such a fuss although in the back rooms, other states lined up to get this. Alas, if only we'd listened a little bit more carefully, not to the tone, but to what he was actually saying, which is red states aren't going to go for this great expansion. You know, there's Nebraska way down the list with Texas and Arkansas. They're just not going to go for the expansion. Anyway, it didn't matter till the Supreme Court came in, and as you just said, and said, no, states get to choose. And so now here we are in this state-by-state battle for the thing that liberals really like. Connecticut, of course they go for it. They were at 190% of poverty. New York, ditto. But the Texas is where the uninsured people live. What about that? So the real question to me, as a bleeding heart liberal, for the ACA implementation is what's going on with Medicaid. And let me give you the quick rundown. The cliche is blue states go in, and sure enough, blue states got in. Red states say no or hell no, depending on how red they are. Texas, for example, has a Republican supermajority. They just wanted to make sure they unanimously rejected a Medicaid expansion. And in Nebraska, the governor opposed. He didn't even suggest it, but the Republicans really wanted it to be introduced in the legislature so they could vote it down. And yet, a lot of the smart money says it's going to happen. Medicaid expansion will happen in most states. And I have to say, I think that's right. So let me tell you why I think, despite all this, Medicaid expansion is, well, let me not put myself on the line. Let me say why the smart money thinks that the Medicaid system is going to expand. First, just a couple of reasons. First of all, of course, if you're a red state, you have to vote this down. I mean, poor red staters. You know, they fought in Congress and they lost, and they fought in the Supreme Court and they more or less lost, and then they fought the 2012 election, which they thought they were going to win, and they lost, and now they get to vote on it. They're not going to vote for it. Of course not. They've got to get that no vote out of the system. But over time, that 90% match is going to look pretty good. And moreover, the hospital payments, the payments to hospitals for uncompensated care, there's federal money for it now. That's going away because this is supposed to cover it. So you've got a very strong lobby in state after red state saying, please, we really need this money. Even the original Medicaid, after 2 years, only had 37 states in. So there's a lot of structural reasons. There's a good deal, the hospitals will be screaming for it, and they're going to need it in many states. And over time, says the smart money, we'll see a lot more states going in. There is another side. States like Texas have a very strong Tea Party. They're well-funded, and they've managed to make this debate about, I was in Montana for the debate, and someone got up and just said, if you pass Medicaid, some large percentage of our 20-year-olds will be on it, and ask yourself, do you want to get Montana's youth hooked on welfare? And that kind of shook people up a little bit, this hooked on welfare. And it has to be said, the map isn't up, but if you look back on the map, there's a lot of states with, let's call it racial questions and tensions, and that's playing in here as well. Does Texas want to ensure a population that's not entirely, but has a lot of people of color in it? So here we have the state-by-state debate, with the smart money says it'll expand, and critics and skeptics saying not so sure. This is about race, it's about poverty, it's about conservatism. If you dig in just a little bit more deeply and look at what's happening, you begin to see the interesting anomalies. First, Jan Brewer, who used to be a bad guy in liberal circles, she goes to Arizona, Republican House, Republican governor, Republican legislature, and she says, I veto everything until you give me Medicaid. The hospital lobby basically told her, we've got to have it. She starts vetoing bills, Republican bills, 6, 7 vetoes. The Republicans are furious, but they cave, and Arizona expands Medicaid. In Maine, they've got a feisty Governor Paul LePage, Tea Party governor, and he's all kinds of things. But he vetoes the Medicaid bill, and the Maine legislature comes within 2-3 votes, House and Senate, of overruling his veto. You've got to guess that with that large a majority in Maine, LePage will go, and Maine will go through. Just a couple more states, and then I'll get to my punchline. I can see Keith saying 10 minutes. You're up against the line. Montana. I have to tell you about Montana. So Montana, it's a real long shot. It's a red state. The Republicans say no way. The hospitals say we're dying. And the Senate, surprisingly, 5 GOP go the other way. In the House, it's very close. It comes down to one vote. The one vote is a Democrat, and he votes against expanding Medicaid. And then he ruefully admits that he actually wanted to vote for it, but it was a procedural motion that said, do you want to return it to committee? So if you wanted Medicaid, you voted no to have Medicaid go. And he got confused, and he voted yes because he wanted Medicaid, and down it went. Montana only meets every second year. See you in 2015, Montana, the legislature, likely to go through. Red state. The state that's most important, and the one to focus on, though, is Arkansas. Arkansas says, we know you liberals want this government program. Tell you what, throw the Medicaid population into the insurance exchange. That is, let's take Medicaid to market, and we'll go along with it. For Democrats, it's an agonizing choice. Remember, Bush tried the same thing, President Bush, with Medicare. Got killed. Now Republicans say, do it with Medicaid. This is the leverage. Do it with Medicaid and we're in. And so, Sebelius, do we or don't we? Well, if you're a Democrat, this is really an agonizing choice. You believe that insurance is tough, particularly on poor populations, but you can expand Medicaid to way high in Arkansas. Sebelius says yes. And all of a sudden, reddish states line up to go in. Pennsylvania, New Hampshire's going to do it this way. We'll expand Medicaid, but on our Republican terms. We want a market Medicaid program. So now, thanks to Obamacare, there is a kind of compromise on the state level. Expand Medicaid, but do it on Republican terms. I think that's likely to be the wave of the future, which is to say federalism is working the way federalism works in America. Throw it to the states, they battle it out, but they've got a problem with health insurance coverage. They can't remain as ideological as the federal government. So my guess is we'll get an expansion, but of a very distinct sort. Democrats get to expand Medicaid, Republicans get to marketize Medicaid, and that's likely to be the wave of the future. I want to make one last point, Keith, and with apologies, and that's this. I think the real future of American government turns on our politics. And there's this to say about the politics. We've never had a period, right through American history, where the two parties are this evenly divided. Every election, things swing or can swing. There's no incentive to cooperate. History suggests that those periods don't last forever. One party is going to break through, and that's the larger frame. If it's the Democrats, this expands. If it's the Republicans, then you have to ask, oh dear, what brand of Republican? And that will have a lot to say with the future of the ACA. Thank you.
I'm going to cover three things in sort of a speed round here. I'm going to pick up actually where Jim left off on Medicaid, add a few thoughts on Medicaid. I want to spend a little bit of time on the issue that Heather flagged, which is this problem of churn. And then I'm going to spend the remainder of my time on the fact, sort of walking you through the fact that if you thought you were done with courts and the Affordable Care Act, you are not. That's why God created lawyers, just to bring health reform to a halt. So let's start with Medicaid. Jim ended on exactly the right note, which is but I would say it differently. What is the pound of flesh that the Republican governors are going to exact from the federal government in order to take up Medicaid? The first pound of flesh was actually exacted by a Democratic governor working with a Republican legislature, and it's not, all things considered, it's not that big a pound of flesh. I mean, I guess a pound is a pound, so maybe it's 3 ounces of flesh. And that was the issue of premium support. In fact, Medicaid statute since 1965 has contemplated premium assistance.
Medicaid programs have always bought insurance, actually. We know it best for buying Medicare coverage for indigent older people, but in fact, Medicaid does a lot of private insurance buying, and so, you know, we get, in most states, there's a big Medicaid managed care market today, and so really, if you buy it from your Medicaid suppliers or your insurance suppliers, may not be that big a deal. And in the Arkansas case, the secretary set out some pretty strict rules about the terms under which she would allow this purchasing. Now, the next wave of people coming in, Governor Corbett, some of the other Republican governors, potentially Democratic governors trying to work with Republican legislatures, the Maine legislature, which is about to roll Governor LePage second time round, they're coming in with a lot more serious asks. So they're coming in asking for the authority to impose premiums on people who are very poor, to hike the cost sharing, to add in behavioral incentives, things like, you know, we're going to hike your copays on you if you don't control your diabetes, and most actually humorously, in a sad way in my view, work requirements. Why do I say humorously? Because most of the people on Medicaid, which transitions me to my next subject, most people who are poor enough to get Medicaid who aren't on Medicaid today are actually younger, healthier workers. A lot of younger, healthier workers. My daughter's a theater director. All of her friends, basically, are eligible for the Medicaid program because they are low income and they're working, and they're just the people you want to have enroll. And so for them, a work requirement doesn't matter. And the other group of people who have been left out of Medicaid are people who are so sick and so disabled. They have not gone through a formal disability test, but they are people who, for all kinds of reasons, are very marginalized. And so a work requirement on them means nothing. But the first point is watch, because what we are seeing, as Jim pointed out, is the shape-shifting going on in the Medicaid program as it begins to align with a new individual insurance market. And that's the second point I want to make, which is the most dramatic thing happening to Medicaid is the fact that for the first time in the history of Medicaid, it is now bumping up against a viable individual insurance market. In the beginning, there was no viable individual insurance market. Medicaid sort of existed. It left out a lot of poor people, but there was this very fragile, almost non-existent individual insurance market. Now we've created one. Medicaid is healthcare financing that doesn't run along the rules of insurance. Insurance is healthcare financing that runs along the rules of insurance and risk and a lot of other things that I won't go into. And the question is, how much is Medicaid pulled in the direction of an individual insurance market with all kinds of rules of the road that have never applied to Medicaid before, the biggest one being the ability, and Obamacare aside, the ability actually to discriminate in some very important ways against people with serious health care needs. Things that Medicaid has always prohibited, that are at the, the ninth circle of hell when you're dealing with your insurance that you would never understand, but ways in which Medicaid works very differently from commercial insurance. So this is the issue to watch, and the people who are caught in this are people who live at the edge of the two markets. They're younger, healthier workers by and large. They're going to churn back and forth between these two markets, and Medicaid is going to experience a lot of pressure to align itself with the commercial insurance market in a lot of different ways, and we are just at the beginning of understanding what that alignment means. We can talk more about that in the break. The final issue, very quickly, is the issue of the courts. So, yes, the Supreme Court has spoken, and yes, they ruined the Medicaid program for the moment, the Medicaid expansion, but we're hardly done. So what do we have looming right now? We have a case that is percolating along in 4 different circuits, 4 different regions of the country, that challenges the authority of the federal government to provide premium subsidies at all in federal exchanges. Case argues basically that Congress wrote a statute that withholds federal subsidy funding from any exchange that's run by the federal government. We can get into the merits of the case. I think it's stupid. The 2 judges who have ruled on it thus far have said this is a stupid case. Why are you here? But it's a real powerhouse case propelled by big name lawyers, and it's in many different circuits, and it's one of the reasons why so many states didn't elect their own exchange. Because this case was percolating at a time when, had the states flipped, had conservative states taken the exchange option, they would have essentially mooted out their case. So we got that thing going on. Then we've got a case going on, going to be argued in the Supreme Court in another few weeks, and on the surface of things, it's your basic religion case. You know, do corporations have religious rights? Can they refuse to conform their employee benefit plans to the requirements of the Affordable Care Act, which cover, among other things, FDA-approved contraceptive methods? Buried in there, though, is the question of whether a corporation, for religious reasons, and we don't know whether the corporations will be recognized as being able to be religious within the meaning of federal law, can a corporation, in fact, excise federally guaranteed entitlements from workers if they believe that those entitlements conflict with their own religious beliefs? So we can talk a little bit more about that. And then cases to watch. So we are just at the beginning of litigation heaven. Okay, and this is the great fun of being a law professor. I mean, you sit there and you spin out, you know, what are we going to see? Well, here's what we're going to see. We are going to see, first of all, a raft of due process entitlement claims. There are people who have been denied coverage because of the malfunctioning of the federal and the state exchanges. There are people who have been denied the coverage to which they are legally entitled. So we're right back in 1965 with welfare rights litigation. There are people who are currently, a whole group of people who have been denied coverage in both markets, okay, because the two markets haven't been aligned yet. The systems don't work together. We have people who have been bounced back and forth between Medicaid and the exchanges. That's going to be a big set of cases. We are going to have cases involving health plans that are excluded. It hasn't happened yet, but it will as states begin to, you know, crack down on the number of plans they'll allow into their marketplaces. We will have many cases by providers excluded from networks. Those are already starting. Providers saying, look, you know, you don't have any legal basis in this state for excluding me, Children's Hospital, you know, a health system, a medical group from practice. And we will also have a whole raft of cases in which people essentially sue their health plans for the denial of benefits and coverage that are otherwise guaranteed them under the Affordable Care Act, but that they are not receiving. Interestingly, the entire federal enforcement mechanism, which again is something that we can talk about in the open time, doesn't exist at this point. There's no federal appeals system in place for people denied coverage. The system of federal oversight for plans and plan administration has not yet really been set up. And so what you're going to see is this raft of private actions that will begin in the way the courts have always fleshed out you know, crucial federal laws. We will begin to see the judiciary beginning to put its stamp on the act, just in the same way that the Supreme Court, of course, affected the act in 2012. Thank you.
Now you have heard three great presentations with incredible detail about Obamacare. I call this American particularism. It reminds me of a meeting we had at the Robert Wood Johnson Foundation, the Princeton conference, and there was a German chap, Reinhard Bussler, some of you may know him, and at 4 p.m. he came to me and he said, I'm not kidding you, I'm literally nauseous and sick on my stomach trying to follow what you guys are saying. So I gave him a Tums and I say, you know, you are just a normal European. No European would ever understand how Americans discourse on health policy. I'm an American citizen. I have a US passport. I probably paid more taxes than most Americans. I'm happy to be an American, but when it comes to healthcare, I revert back to my immigrant status just off the boat, looking at you and saying, how could this be? Did God actually create such people? Now, one thing I have learned talking about God, that you worship three things. One is God, second is GDP, and the third is choice among health insurers. I don't quite know the order of that, but those are the three things. Now, Ted Marmor and I have had many exchanges on this topic. I blame the citizens. He blames the structure of governance the Founding Fathers gave us and the interest groups who crammed this down our throat. I don't know who is right. I'm an economist. I assume I am. And that's one thing we can do in economics is make assumptions. I think, though, the issue of choice, a lot of Americans want choice of insurer and policies so that they can avoid paying for their brothers and sisters, like maternity care and so on. So part of it could very well be in the soul of the individual. But Ted and I one day we'll figure this. Maybe we'll write a book together and figure this out. Now, again, if no one in Europe would understand how a nation can be so fanatic about freedom of choice of insurer that it would bargain away, as you have, freedom of choice of doctor and hospital. Think of what a strange deal to a German, to a Canadian, you know Canada, to a Taiwanese. This would be unthinkable, to give up freedom of choice, narrow networks, so that you have freedom of choice of insurer. That's the deal you have made. And a lot of what we hear grows out of this choice, whether it was a clam down or a choice, I don't know. So much of the agony, that's my first proposition of Obamacare, is over this issue of choice. Secondly, in this country, we do not have an agreement on the social ethic. There are really three groups, roughly 1/3 each. 1/3 believe, like Canadians, healthcare is a social good that should be available to everyone on equal terms, regardless of ability to pay. At the other extreme, you have people who believe healthcare is just a private consumption good. In the first instance, the individual's responsibility to pay for, although we might concede to give a bare bones something to the poor. And in between, you have the sort of the independents who have an even numbered days, one view, and an odd another one, depends what their last experience was. Each 1/3, I use that because it adds up to one. So in any health reform plan in America is a half-hearted, it's a combination of half-hearted social solidarity and half-hearted rugged individualism. In New Jersey, we have another term for half-hearted, but I think this may be outside of New Jersey. Go to Massachusetts, they don't use it up there. Obamacare is a classic example of this sort of half-heartedness all around. There is gestures to social solidarity and to rugged individualism, and so on and so forth. Half of the law is designed to help citizens, and the other half of the law is designed to keep people out, right? Because that's what we were talking about earlier. That always happens, all these strictures about eligibility. There was a meeting yesterday in Washington, the Center for Budget Priority. It was about eligibility, and just defining what a dependent is awesome. You need lawyers. Or what a household is. There's a classic paper that was written in 1992, Chuck Phelps, on an apple a day, where the Clintons had agreed apples should be covered in the insurance policy. And it took 2 years to define an apple in this thing. When we discussed implementation, we focused on the exchanges, etc. To some extent, I think that's unfair. That's only Title I, which is a core piece of the bill. However, there were many other things that have been smoothly implemented to great popularity. For example, pre-existing children for kids could no longer be used to exclude kids from coverage. That came in right away, didn't it? That you could keep your children up to age 26 on your employer's provided policy. Very popular, came in really fast, without much fanfare. ACOs, they're not all going to work, but the move to integrated care, accountable health care, I think it's well underway. And again, it's complicated and has its bumps. The Center for Innovation at CMS is a great new invention. Demonstrations for payment reform. This PCORI isn't really, this is the Patient-Centered Research, Outcomes Research Institute, was actually in a stimulus bill, but one could really consider in spirit it's part of the ACA. All of this has gone forward. No one said thanks, although people should have. And I find it very encouraging that the private sector has discovered private exchanges. It took the government to show the way, mind you, with exchanges. I mean, real insurance exchanges of the sort the government now introduces. So the bottom line for me, people often ask, on balance, are you happy Obamacare is there or not, or is America better off? Journalists always ask that, even in Europe. I would say yes, we're better off. If you gave me a choice of in America the way it was, or with Obamacare, with all its kinks and wrinkles, I am happier with what we have, because we will help people. In fact, I just had someone here at Princeton I know who had an operation. She was not insured. It was in December. Right now, she's stuck with the bill. Had that been in January, she wouldn't have this problem. I consider that progress. She had cancer. So yeah, it's better off. Are we at a point of no return? I think so. I think a repeal is no longer there. Smart Republicans realize that. They're talking about how to change it. And that is, of course, their privilege if they should win the House and the Senate. But I don't think that law is going to go away anymore. Given the way we make laws in America, for better or for worse, that's the system we have. Could I have done better? Absolutely not. Not with this system of governance. I don't think I could have done better. I probably would have done worse than President Obama. But given the way we make laws, every law needs fixing. Every law needs fixing. And Medicare was fixed, every conceivable law I can think of was fixed on the way. This law needs some fixes. We policy wonks know what they should be. I think Paul Starr had a great idea to replace the mandate with an option. You don't have to be insured, but if you don't take insurance now for the next 5 years, you cannot come on the exchange and you can't get a subsidy. I think Paul is much too gentle. He's a very gentle soul, as you know. I would have made that for life. You join or you don't. And I've written that up in the New York Times. I say, your rugged individualism, you can have that branch and stay there. Don't ever come crawling to me. Or you can join the social solidarity, and yes, you will pay for mothers having children. That's part of social solidarity, and you could choose that for life. That would be my approach. I think if we had a government again, that is, I'm talking about legislators who love their country more than their party. You don't remember that anymore, but there was once such a time. If we should have that again, we could fix this bill, and we'd have a great bill. Thank you very much.
Well, thank you all for bringing the smart money here. And for now, what I'd like to do is maybe open it up to questions or comments. I'll try to acknowledge you if your hand goes up. Maybe we'll gather about 2 or 3 questions, and then we'll turn it back to the panelists. Sir.
Okay. This is a question about the uncompensated care fund. I'm familiar with the state of New Jersey. A lot of inner city hospitals are on the brink. They're going to get less money going forward, and there seems to be a very delicate balance with them getting enough uninsured into either Medicaid or the exchange. And I've talked to hospital administrators, oh, we did modeling, we did this, we did that. Is there any kind of safety net if their modeling is a little off and they, in fact, wind up with less money than they have today? Any comments?
So let's, if you don't mind, we'll just gather a few.
We talked a lot about how states are using their leverage over the federal government to implement the Medicaid extension. To what extent is the government going to bend over backwards to expansion happening? Like, what are they willing to give up in order to get this passed?
One more.
I detected a faint touch of derision when the speaker referred to behavioral incentives. Now, without commenting on governments, local or otherwise, taxing superstars,
Oh.
We'll
We'll repeat the questions.
We'll
Yeah.
repeat your answer. Yeah.
There's also a microphone right there if you...
Oh, maybe it's just.
well,
Okay.
without commenting on the wisdom of government taxing large cups of soda, since, for better or worse, as the speaker just remarked, we are pretty much in ACA as a fait accompli. What is wrong with some behavioral incentives? It would seem to be a win-win proposition, the individual benefits, and we could probably chop a third off of the medical share of the GDP if people lived moderately less absurd lifestyle.
Great. Three great questions. Uncompensated care, what is the Fed willing to give up, and the question of behavioral incentives. I said it was a free-for-all to these.
I can start with the uncompensated care because I know well New Jersey's fund. I would make it more than just an urban hospital actually issue. We're seeing this play out in the South where rural hospitals are failing and governors don't want to expand Medicaid, and so they're putting state dollars to bail out hospitals because they don't want to expand Medicaid. But if the expansion of Medicaid would probably save those hospitals. So I think something to watch that's really interesting is how sustainable is that? If you're Alabama, Georgia, Mississippi, that's not very sustainable. And so the federal government delayed those cuts in hospital funds, the dish cuts, but that's going to hit the hospitals. And so that dynamic of hospitals standing up that both Jim and Sarah referenced is going to become more acute as those cuts come to bear. And again, those, how sustainable is it when governors have to balance their budgets every year and they're talking about putting their own scarce resources to prop up a hospital when the Medicaid expansion would solve that problem.
Just to give you an example, in Virginia, the state legislature offered, what was it, Judy, about $100 million, and the hospital industry met with the legislators yesterday and said under the expansion we'd get $700 million. Now, you asked, though, an additional question, which is what if the calculus is wrong? What if their projections of what they're going to get under the insurance expansion is off? And there, I mean, in theory, the dish funds do start coming down. Obviously, Medicaid still gives states enough leeway so that they can adjust their base payments to hospitals if they wanted to. And so there's a fair amount of flexibility to deal with being off the mark. But we didn't talk at all in this session about what's going to happen to safety net facilities, whether they're ambulatory or inpatient, and that's a very serious issue.
I think your question is a very serious one, actually. And Heather, we wrote a big report for you guys, and in it, we did a financial analysis of hospitals, and I was stunned. We arrayed the hospitals from low margin to high margin, and they were about 25%, maybe not 15% actually negative margins, and then the sort of a big middle, 3-ish, 5-ish, which is fine, and some were rolling in dough. So when I looked at that, I said, we already have a two-tier system because there's no way that hospitals that make 12% margins will look the same as hospitals that have -1 if you keep going. So that it's a choice the American people face. We swept this under the rug without debate. I think we should debate this. Should we have a two-tier system? One for the poor, one for the rich? Or shall we help? Say Beth Israel Newark, I think, as I recall, was one of them, in particularly the northern urban city. They were negative margin on the coast. They were really doing very well. And I think all of that happens, and the trouble with the hospital associations, they hide as a group behind those low margins and ask for more money, but often the money doesn't go to the poor ones. I think we should have an open debate on this and say, what are we going to do with these inner city hospitals? How can we subsidize them without giving these subsidies to everyone else? Because Heather, you will remember a lot of the subsidies actually flowed to hospitals who were the last who needed it. That's a very good question.
It is a good question, and just to follow up, it's really, I mean, it goes to the heart of the American social policy regime, right? I miscalculated and my hospital is in trouble. And so really reflects the Uwe's presentation. I want to say one other thing, though. These hospitals have huge hostage populations. That is, people who can't pay, who are poor, and who go to that hospital. If that hospital goes under, every other hospital knows they're coming to me. So they're all in this together, and that changes the dynamic. It's not just that hospital. There's a great case in Maryland where one hospital went under and there came the wave. I was talking to the administrator at the next hospital over the Baltimore line, and he's saying, we'll do anything to keep that hospital because those people come to us next. So that changes the political dynamics, the hostages. I love your question, where are you, about what you're willing to trade off, because that's the great question, particularly in a Democratic administration, where you want the expansion and you want to draw lines. And other people have more to say about this than me, but what really strikes me is Sebelius and her group are really saying, we're not 138%. We won't negotiate about that. Almost everything else, there is a lot of negotiation going on, and I think every social democrat has to decide for themselves, what would you give? What kind of trade-off would you make? And Republicans will make different trade-offs. And very quickly, you know, in a rational universe like this, behavioral incentives make ever so much sense. If you could just try to tweak them. There are people who say, no, that's not true. I don't want to argue with that. I want to argue with, in the real world of politics, there are a lot of different populations. And there are a lot of tensions, black and white, Latino, immigrant, poor populations. And in the real world of politics, behavioral incentives kind of drift in to getting really tough on those people. And that's why people sometimes disparage it. It's not the behavioral incentives themselves, it's how they get used in a society with lots of different cultures that clash.
If I could just add on that point, because I think I'm the one who flagged it. There are two kinds of behavioral incentives, and actually it's not just for poor people. The wellness program amendments in the Affordable Care Act allow the use of a lot of behavioral incentives in employee health benefits as well. So there are participatory behavioral incentives. You know, join a gym class, to go into a nutrition class, whatever. And then there are the outcomes incentives, and I think it's really the outcomes incentives that are worrying a lot of people. To tell somebody that either you control your diabetes or you're going to experience a hike in your co-payments or your deductible seems to be sort of counterproductive. And I think Jim's exactly right. The question is, are we going to be more ambitious in experimenting with outcome incentives for people who don't quite have the ability to push back than we would be for ourselves and our own employee plans?
Well, statistically speaking, type 2 diabetes is reversible.
Absolutely.
It is, but I'll just jump in, but you need...
But the question is whether you condition somebody's affordable insurance coverage.
Right, that's right. And how you do it, and do you recognize that that person may have significant barriers to taking up those behaviors? That person wants to control their diabetes too, but do they have access to healthy food in their neighborhood? Do they have any place to be able, you know, do they have the ability to change their diet in a way that we might all agree is desirable?
I'd be curious as to the panel's perspective on the erosion of employer-sponsored health insurance, which seems to have been, if not occasioned, then accelerated by the implementation of the Affordable Care Act.
Well, actually, I would argue it's just the opposite. I mean, I think and this is where Uwe knows vastly more than I do, but the Affordable Care Act, and I think it's not gotten a lot of attention, is a line in the sand. It's the act draws a line in the sand and says, if you are an employer of over 50 full-time employees, you have to offer a plan. Never in the history of federal law has there been anything like it. Now, of course, you don't have to. You can pay the penalty instead. I think, given where employer-sponsored benefits are going, and particularly dependent coverage, you know, which is just a train wreck at this point, to have a federal law that says, as a matter of federal obligation, as a workplace obligation, if you're a larger employer, you have to offer benefits. Even if we're now tiptoeing around the requirement and we're delaying implementation, the question is, in fact, whether it has any ability to stem the slide that I think is already heavily underway. And absolutely, in the case of small employers, I can't imagine a small employer who would continue to try and struggle to offer an employer plan, except in very rare circumstances, once the exchanges are up and going. So,
but, this is not something perhaps we should worry about. If you draw a random sample of economists, probably all of us would say, ideally, if we could do it from scratch, we'd never have this system. So it's a little bit like diabetes. You got it, you can't get rid of it. But now I'm glad that it's reversible. Because a lot of us have actually been dreaming of getting rid of this system, particularly for small businesses and entrepreneurs, so that, in fact, people have portable insurance that's permanent and so on, and business can just make widgets and compete. If a business wants to offer it, fine. It's actually just a substitute for paying cash compensation. They give them benefits. But ideally, a policy that you lose when you lose your job is really not insurance. Somebody once called it insurance. This is not really a good deal at all. And America is the worse for having it. And then on top of it, you couple it with a subsidy by making this all tax exempt that benefits mainly the rich people and not the poor and lower income employees. So I think the more people drop into the exchanges, most economists would probably say the better off we are for economic growth.
Yeah, I'm just going to agree, but it's worth focusing for just a second on how we got here. The usual story was kind of random, World War II, but that's not really right. The Eisenhower administration was very worried that we were going to go to national health insurance and wanted to put a wall between government-supported health insurance. So they took a program that was collapsing in the 1950s because of lots of tax decisions, a program from the World War II, and put it solidly into place. So this was a barrier to national health insurance. And you know what? It worked great in the 1950s when you had stable employment. My dad came home once and announced that his competitor had offered to double his salary if he'd move jobs. My mother said, "Jimmy, that sounds like a good idea to me." My father was shocked. How would it look if I just changed jobs for money? Now, it makes my dad look like an idiot. But back in the day, that's how people thought. You took a job for life. So it made some sense to have this employment. I know the economists didn't like it, and the liberals wanted national health insurance, but it still made sense. Those days are gone. So we're trying to patch up a system that belongs in a different era. So I'm with Uwe, and I hate to agree with an economist, but he's right.
Other questions? We'll take a couple.
I'd like to hear panelists' thoughts on liberal reforms to the ACA and what the most likely vehicles are for that, whether that's multi-state plans or whether it's extending the subsidies upward into the middle class or stuff that's more focused on the state level.
I think the absolute crucial issue is affordability. You want to get more?
We're taking multiple.
One of the issues that has not gotten a lot of public discussion and that can have a significant economic impact is forcing as much care as possible away from the hospitals into outpatient settings. Many Medicaid patients in particular don't think about having a primary care physician, they go to the emergency room. And there's very little way that is available to discourage that kind of behavior because nobody gets turned away from an emergency room. And I think those are the kinds of issues, if we can have an impact, will have a significant economic impact and perhaps impact what we're talking about in the political.
I saw one other hand up here. No? Okay.
I'll start. I'm glad you raised that about the issue of home and community-based care as opposed to institutional care. And there's a movement towards, because I think people get that people would rather age in place in the community and that's ultimately cheaper for state budgets. And so you're seeing some movement there but not enough. And one of the great pieces of unfinished business in the ACA is the failure for us to have a long-term looking at one of the great authors, Judy Fader, in the audience, who's not paying attention. Judy,
She's quoting you.
One of the great failures of the ACA is to secure a solid system of long-term care insurance. So we don't have, there was a provision in the ACA to provide called the Class Act that would have provided for long-term care insurance, and that was the administration declined to implement it. I guess it's fair to say they found it wasn't sustainable. So this issue of long-term care, to me, is really unfinished business of the ACA, and we're moving there on home and community-based, and states like New Jersey are doing more there, but we need to do more, but we can't lose this fact that we need to do more to ensure that people are able to stay, people are able to stay home as long as they can. So I think that's a great issue to say. And to Galen's point, I like how you phrase it, Galen, because there aren't going to be reforms to the ACA coming out of Congress. So maybe you'll see on the state level some states trying to do things like, how do we address churn in a way? Can we do it creatively? How do we make our Medicaid program work with the exchange better? How do we protect consumers from narrow networks and make sure they have access to doctors? So I think the place to look for those kind of reforms is in those states that are embracing ACA and trying to find ways to adapt it.
I think the absolutely crucial issue is affordability, which everybody knew as this was moving through Congress, that affordability, going to the point that Uwe made before about Paul Starr's substitute option, it would work actually probably pretty well if you could have a really affordable product. And the terrible problem facing people between about 138% of poverty and all the way up to 400% of poverty is that the subsidies are just not enough. They're not enough at the premium end, and the cost sharing reductions drop off real fast. In terms of having a vehicle, I'll tell you what my mother would tell you, it's Purim. That's when we'll have a vehicle. I mean, there's just, nothing is happening. And so having a time when we can debate infusing another $100 billion into the system is like never.
On this emergency, getting healthcare at the emergency room shouldn't actually cost a lot more money. It's just the way hospitals bill. They find that a vehicle where they can bill you way above the incremental cost. I always sort of kid with students to say the cheapest way to get your car washed is the fire station, because when they're not putting out fires and they wash your car, it's free, essentially. It costs the country nothing. And the same is true with emergency room. When they don't have emergencies, in theory, their care should be actually fairly cheap. The problem is it's not integrated, it's not a medical home, there isn't continuity. So it's more the clinical side that is deplorable there than the economics. Although Heather, who sat over a budget, they of course get charged a lot more. She again saw that a little bit differently. But if you were to convert the emergency room to be also a medical home, some of these problems would go away.
So let me throw in one of my own questions and then highlight two others. So what I take away from the panel discussion so far is to looking ahead, we have to pay attention to the legal venue, because some of these issues, the structure as well as the political dynamic that play out in the law. There's this dance that's going to go on between the state and the federal sector, what kind of latitude the federal government will give to some of these states who are on the fence. There's the kind of shifting economic calculations, particularly hospitals, and the kind of pressure they bring to bear in the states. I wonder if we could talk a little bit also about the politics. And one of the reasons why we're here is because Obamacare makes good politics. And we're likely to see it play out in the coming elections this year. So I wondered if the wisdom of this group has anything to contribute to our understanding of how Obamacare and its implementation will play politically. Because in some ways, much of the question of whether it's a success or a failure is ultimately one that's connected to electioneering, and political strategizing. So I wonder if you had any insight on that, and we'll add 2 other questions to that.
Well, I have a question about what impact Obamacare has on people who are well employed. They're employees at Princeton University. They're very well covered for health insurance. Most of what the panel has been talking about is Medicaid and Medicare, where lower income people or people who are not covered, what impact it has. And we've talked about execution of the plans after they come in place. But what effect does Obamacare going to have on people who are currently well covered by a very strong employer? Should they have anything to worry about, or will anything in Obamacare affect their current plan?
And one other.
You talked about how when Medicaid now might have to sort of compete with, sorry, with the individual market, so like Medicaid will like that like Arkansas. So do you think that will be helpful in the end towards like making things more efficient and like higher quality, or will that sort of, I don't know.
Yeah, so the Arkansas plan, will it be effective to put Medicaid patients into an exchange?
Towards like managed care, like more of those.
And we'll add 1 more, and then we'll throw it back to the panel. Sir.
So Heather alerted me to the phrase doc shock a couple of weeks ago, actually. And so I'm really lucky because I'm really old and I'm on Medicare. I want. But I've had this running debate with some younger friends of mine who both signed up for the silver plan under the exchanges. And even the silver plan, they found that some of their key doctors would not accept the silver plan. What does the panel think? How will this play out over the next 2 or 3 years? Will doctors find enough people, enough customers, if you will, patients, are on exchange plans so they have to accept them? Or will things change so that doctors might be required to accept plans? What's going to happen?
Great questions.
I would actually start with this last question.
Yes.
I think it's a really important question, and I go back and forth in my own mind. I think it's going to depend on a lot of underlying aspects of the state's insurance market. In some states, the silver plans, Heather's slide showed you, of course, they're heavily subsidized, but we don't know, I guess we don't really know yet whether the subsidized people are at the lower end of the subsidy scale, meaning between 138 and 200% of poverty, or people getting a mild discount but not the deepest discounts. And I think the issuers of silver plans don't quite know how to market themselves at this point. There are a bunch of plans that are coming actually out of the Medicaid managed care market. They are marketing themselves as continuity plans, essentially, for people who are those churn people. So they're people who earn, they're working 30 hours a week, and sometimes they bump up to 40 hours a week and then back down to 30 hours a week, and so they move, their subsidy moves. And then there are silver plans that may be sort of positioning themselves to be at the young, hip adult, like my daughter's friends, the actors, who are, they're everything, a young hip adult would be, except their earnings are relatively low. And they seem to be sort of positioning themselves differently in the market, and I think what we're going to see is even more than variability in benefit design from silver plan to silver plan. We're going to see a lot of variability in network, depending on how the silver plan is attempting to position itself in the marketplace. So I think there's not going to be any one answer to the question.
I think on the last question, we've been talking now about an impending doctor shortage for some time that precedes Obamacare. First, in the 90s, it was a surplus. We were supposed to, Jonathan Weiner wrote a paper, 38% of physicians won't be needed, and so on. So we eggheads really don't know what the right number is, but the religion at the moment is we're going to face a shortage that will be exacerbated a little bit, I think less than some critics say, by Obamacare. Some of us, I belong to that school, say, we actually have to revisit the model of the medical practice. to engage more nurse practitioners and others. And there are these models. People who will be finicky and want even routine checkups done by a physician may have to pay, and they might not get it through a silver plan if they go. I think there'll be some tiering along that. I don't actually believe that that'll be tiered by quality. I think a practice that relies very heavily on nurse practitioners could be a pretty high quality practice if they're well trained and the doctors work. Now there's an ugly fight in California between the nurse practitioners and the medical association, because the doctors say, we're okay with the NPs as long as we control them and supervise them. And the nurse practitioner says, why can't we hang up a shingle and just compete with these docs, as they can do in New York, for example. So that'll be a fight upon it. I'm in some way less worried. I think Americans are flexible enough. We'll work through that issue. I think of all the Obamacare things, this one worries me less than others. And we did, of course, have concierge medicine that started about 10 years ago, and with the spreading income distribution, a lot of high-income people, they'll all have concierge physicians who will see far fewer patients, and so on, and that'll exacerbate the shortage. But I think that'll work itself out. I would actually not naysay Obamacare for that.
I'll pick up on that, and I agree that I think it will work itself out, that consumers will vote with their feet. And do they like those narrow network plans or do they not? There's an interesting poll out today that shows a majority of people would pay more to have a broader network. But if you dig deeper in the numbers, a majority of uninsured people prefer to have a cheaper premium and will live with a tighter network. So if this is about reaching the previously uninsured, it's more important to get them in and get them covered. And if the price is a narrower network, that's a price we may be willing to pay. And of course, it's possible that narrow networks allow a carrier to drive for higher quality improvement. So I think that's something to watch. Keith, to your question about the impact on politics, there are several, I think, gubernatorial races this fall in which the governor's handling of implementation will play an issue, which will be interesting to watch in several states such as Maryland and Minnesota, where implementation has not gone smoothly, and will governors pay a price? It will be a question to watch. But then the flip question may be in a state like Pennsylvania, we may get a switch in party in the governors, and then we may see a quick acceptance of the Medicaid expansion where there was a reluctance under the previous Republican governor. So yes, not surprisingly, politics will play a role.
I want to comment on the politics too. For starters, you're going to hear tons of stuff about how the midterm will be shaped by the response to Obamacare, and that's a lot of hooey. There's structural reasons. Mark Peterson could give you a long lecture on it. There's lots of structural reasons why Republicans are likely, but not certain, of course, but are likely to take over the Senate. It really doesn't have to do with Obamacare. And to put it differently, my guess is this result, this midterm, won't come out differently if you could do the mental test of removing health care entirely from it. It'll go not that differently. So pay no attention to this Obamacare. It's a vote on that. It's a vote on lots of things. And there'll be a lot of talk about Obamacare, but I think that's a false story. Having said that, you can't escape health care. We did a study of presidents from Roosevelt to Obama, and there's lots of presidents. George Herbert Walker Bush was the most extreme example, who hated the issue, just couldn't stand it. But it seeks you out and finds you. He couldn't escape it. And given that, both parties need a healthcare platform. And I have to say, for the immediate term, Obamacare is the crack cocaine of the Republican Party. They can't think straight. The Republican Party has actually been much more creative than the Democrats in coming up with new healthcare solutions. Whether it's Nixon or George Bush, son George Bush, they've just come up with lots more ideas. Which ideas the Democrats steal and say, well, we'll try that, only to have the Republicans turn around and say, horrible, socialism. So for the Republicans, I think Obamacare, okay, they fought the good fight. It's not the good fight anymore. And I think it's freezing the creative ideas that have been part of the Republican healthcare strategizing. You may like them or you may not like them, but there's been a lot of them. What's really interesting is what's going to happen to the Democrats. Will they start moving back to a sort of, well, social democratic position. When you find that this was so much trouble, let's stop stealing ideas from the Republicans and begin to move perhaps in a direction for Medicare for all. So who knows? But watch in the medium term how the parties plot their next steps, because healthcare doesn't go away, and every plan and every change breeds the next set of reactions. And one final point. There's a lot of talk about how government has been thoroughly discredited by the rollout of Obamacare. If you're a certain age, you will remember the exact same conversation took place when Reagan and the Democrats conspired to pass something called catastrophic care. It lasted a year. Seniors banged on the limousine of Dan Rostenkowski, and everybody said, well, that's it for health care for a long time to come. Who's the next president? But Bill Clinton. It's the economy, stupid, and don't forget health care. It doesn't go away. The great political question is how each party takes this lesson and redesigns its health care plans going forward.
Great. Thank you. Let me, before we thank the panelists for this really wonderful, you might say, orientation and understanding of where we stand today and where we're likely to be in the months and years ahead, let me mention a last word on behavioral incentives. That is, I could have mentioned beforehand that there's a reception next week, but I chose to think of it more as a reward for good behavior. So, for those of you who sat through this really stimulating conversation, please join us in the next room in the Schultz Dining Hall for